Bipolar and related disorders. Bipolar disorder falls into two separate categories, bipolar 1 and bipolar 2. Cyclothymic disorder is a similar mood disorder to bipolar. There is some differentiation between bipolar 1 disorder and bipolar 2 disorder. The main difference is that bipolar 1 disorder is more characterized by a manic episode, whereas bipolar 2 disorder is more characterized by hypomanic episodes and a major depressive episode. For a diagnosis of bipolar 1 disorder, it is necessary to meet the following criteria for a manic episode. The manic episode may have been preceded by and may be followed by hypomanic or major depressive episodes. For a diagnosis of bipolar 2 disorder, it is necessary to meet the following criteria for a current or past hypomanic episode and the following criteria for a current or past major depressive episode. Bipolar 2 disorders are not a milder form of bipolar 1 disorder. Individuals with bipolar 2 disorder have greater chronicity of illness. Criteria B for a manic episode includes 3 or more of the following symptoms are present: inflated self-esteem or grandiosity, decreased need for sleep, more talkative than usual or pressure to keep talking, fight of ideas or subjective experience that thoughts are racing, distractibility, increase in goal-directed activity, excessive involvement in activities that have a high potential for painful consequences. Criteria C for a manic episode. The mood disturbance is sufficiently severe to cause marked impairment in social or occupational functioning, to necessitate hospitalization to prevent harm to self or others, and there are psychotic features. Criteria D for a manic episode. The episode is not attributable to the physiological effects of a substance or to another medical condition. We will now discuss the criteria for a hypomanic episode, which is necessary for a bipolar 2 diagnosis. The main difference between a hypomanic episode and a manic episode is the length that it lasts. Criteria B for a hypomanic episode include 3 or more of the following symptoms are present: inflated self-esteem or grandiosity, decreased need for sleep, more talkative than usual or pressure to keep talking, fight of ideas or subjective experience that thoughts are racing, distractibility, increase in goal-directed activity, excessive involvement in activities that have a high potential for painful consequences. Criteria C for a hypomanic episode include that the episode is associated with an unequivocal change in functioning that is uncharacteristic of the individual and not symptomatic. Criteria D for a hypomanic episode include the disturbance in mood and the change in functioning are observable by others. Criteria E for a hypomanic episode include that the episode is not severe enough to cause marked impairment in social or occupational functioning or to necessitate hospitalization. If there are psychotic features, the episode is by definition manic. Criteria F for a hypomanic episode include that the episode is not attributable to the physiological effects of a substance, for example, abuse of a drug, a medication, or other treatment. We will now discuss the criteria for a major depressive episode, which is also necessary for a bipolar 2 diagnosis. Criteria A of a major depressive episode include 5 or more of the following symptoms have been present during the same 2-week period and represent a change from previous functioning. At least one of the symptoms is either 1, a depressed mood, or 2, loss of interest or pleasure. Continuing on for criteria A, it includes depressed mood most of the day, nearly every day, as indicated by others, markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day, significant weight loss when not dieting or weight gain, or decrease or increase in appetite nearly every day. Insomnia or hypersomnia nearly every day, psychomotor agitation or retardation nearly every day, observed by others, fatigue or loss of energy nearly every day. Feelings of worthlessness or excessive or inappropriate guilt nearly every day, diminished ability to think or concentrate or indecisiveness nearly every day, recurrent thoughts of death, not just fear of death, recurrent suicidal ideation without a specific plan, or a suicide attempt or a specific plan for committing suicide. Criteria B for a major depressive episode include if the symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Criteria C for a major depressive episode include that the episode is not attributable to the physiological effects of a substance or another medical condition. Bipolar disorders can differ in their level of severity, including mild, moderate, or severe. The severity is based on the number of criterion symptoms, the severity of those symptoms, and the degree of functional disability. We'll now discuss the choice of medication for bipolar and other related disorders. The first choice of medication include mood stabilizers, the main one being lithium. Lithium helps reduce the severity and frequency of mania. It may also help to relieve or prevent bipolar depression. Lithium is generally prescribed for a long period of time and may significantly reduce suicide risks. Some of the other mood stabilizers include Depakote, Tegretol, Lamictal, and Trileptal. The second choice of medication are antipsychotics, the first one being haloperidol. Haloperidol is used to treat certain mental and mood disorders such as schizophrenia and schizoaffective disorders. This medicine helps you think more clearly, feel less nervous, and take part in everyday life. It can also help prevent suicide in people who are likely to harm themselves. It can reduce aggression and the desire to hurt others, and it can decrease negative thoughts and hallucinations. Loxapine is another antipsychotic similar to haloperidol. Loxapine works by helping to restore the balance of certain natural substances, such as dopamine, in the brain. The third choice of medication includes sedative hypnotics, such as benzodiazepines. This class of drugs, referred to as minor tranquilizers, include alprazolam, diazepam, and lorazepam. These are sometimes used for short-term control of acute symptoms associated with mania, such as agitation or insomnia, but they do not treat core mood symptoms such as euphoria or depression. They can also become habit-forming, so they need to be closely monitored. Individuals with bipolar disorder who start benzodiazepines and/or Z drugs, particularly alprazolam and clonazepam, have an increased risk for long-term use, resulting in an increased risk for adverse effects associated with these medications, according to an analysis published in Bipolar Disorders.
I was first diagnosed with bipolar 2 back in 2008. I had just been through a 4-month intense mania, which I did not understand that was what was happening. During that time, I decimated my life, the life of my children and my husband, asked for a divorce, sold our house, kicked him out, and was just in the process of what I thought was, oh my gosh, I finally did it. And instead it was, when I got through it was, oh my gosh, I did that. What got the diagnosis was that I then crashed. And the crash was so low that I honestly felt I was dying. I could no longer fathom how I was going to take care of myself, much less the 3 children who were 7, 10, and 11 at the time. So on one day when it was at its worst, I called my husband, who had moved out, and told him, I don't know what's wrong with me. I cannot function. I am so scared, and I have no energy. So we called Mercy Franklin, told them what was happening. They said, come in right away. And next thing I knew, I had been admitted to a 5-day outpatient program. And on the first day of being there, I went to talk to a doctor, and that doctor after asking questions, finally said, well, I believe that you are bipolar. I was devastated by the diagnosis because at least 6 or 7 years earlier, my oldest sister had been diagnosed with bipolar. And she has a almost completely opposite personality than me. Is narcissistic, has borderline personality disorder as well. And it was just everybody's favorite topic of conversation to analyze whether or not she truly was bipolar, or if, okay, maybe she is bipolar, but she completely uses it for her benefit. She was one of those that would feel better, take herself off the medication. They were constantly tweaking the medication. And so I didn't want to become the next person in the family that would be, the topic of the day. Much less I didn't want to be bipolar, because I had seen the devastation to her life. And then, of course, I was faced with the devastation that I had just caused to my life. And what's awful about coming out of a mania is that when you're in it, the voice of reason, the one that can make good judgment calls versus bad, is behind a door, and you can hear it, but you can't access it. And so you keep making all these bad decisions, one after another. Well, when you crash, it'd be great if you couldn't remember the details, but you do. You remember every single horrible, misguided thing that you said and did. At least I did. And the weight of that did not help in wanting to live again. But what I also realized, and which actually kind of helped, was that a lot of the poor judgment calls that I had were identical in nature to the ones that my sister had. And so to see that there were commonalities for those people with the illness made me realize that this is real, that this is a function of the brain, and it acts similarly among people. So as far as how it affected relationships, how did it not affect them? Obviously, it greatly affected my relationship with my husband. We did salvage the marriage. He was fantastic in helping to get me back to full strength. I mean, literally spoon feeding me, getting me out of bed, helping me take a walk by half carrying me. And he was fantastic about that. When I finally was functional, feeling, somewhat much better, he then started holding it against me and reminding me on a regular basis, like maybe every 3 months, that he did take me back out of the kindness of his heart, that it was probably a mistake, and that who I had been during that mania was the real me. That even though that behavior had never been exhibited in any way during the first 15 years of our marriage, finally the real me had come out, and the one that he always knew I would be. And so he never let go any of the things that happened, which made it a lot more difficult for me to forgive myself. The next relationships that were incredibly affected were my 3 children. It is almost impossible to forgive myself for what they endured because of my mania. And I feel such guilt. I see some residual effects on their own mental health because of what I put them through. I just, it was very difficult to feel like I could be a good mother to them because I'd been such a horrible mother during those 4 months. As far as any friends go, I lost them all. I'd had a strong friends group from my church, and nobody wanted to be friendly with the person with problems because it brought them down, is how I believed it was. There was just one friend who I'd known from a different reason, not from church, and I'd known her longer. And she did stand by me. And for the most part, she treated it as if it was just a blip and moved forward, listened if I wanted to talk. Just, it was normal if I didn't want to talk. So I was very, very grateful for her.
For the most part, I use the same interventions with and skill set, the basic skills that I would with anybody coming in for any reason. When working with somebody presenting with specific diagnostic criteria, such as, any level of whether it's a severe depressive episode, somebody with major depressive or generalized anxiety, obsessive compulsive, anybody with schizophrenic traits, or then bipolar, whether it's one or two, is the basic mental health techniques I use. Is building that therapeutic relationship is vitally important, and kind of getting a general idea of what's coming in. As far as working with someone with a bipolar disorder, is a lot of assessment on if they're aware of it, whether that's something that presents over time, if it's something they're aware of and coming in specifically to work on and find support with. Similarity, I think it's important to see the person and not it's easy to get stuck on diagnosis. And so being able, everybody's a person. So, so similarities are people, and everybody's got their personalities and life experience and interest and everything else. The main difference is just how they're experiencing, so the symptoms. So I find, so with the manic or hypomanic, or when those episodes happen, the biggest challenge is the impulsivity. So excessive spending, increased self-medicate, substance abuse, sexual activity, kind of stuff. There's a couple sticks out. One that is always stuck with me. I did my internship at Allen on the emergency mental health unit. So it was folks that were suicidal, in some level of psychotic break, or I don't think we had any threat the whole time I was there. I don't think we had any homicidal clients in those stages. But there was, and we get who we got on the unit, but there was, we had a individual who was diagnosed as bipolar, but was kind of in the early stages of what that meant for her, in a very manic episode, and running around the unit, taking her clothes off, a lot of manic behavior, generally inappropriate, but manic, understandable in the manic. And then we had another individual in there, and just, we were talking, and she was, so the one in the manic state had been committed. This woman had been, it's been out of it long enough, I forget the language itself. She came in on her own, and we were just having a conversation, and she goes, "Wow, that used to be me. 20 years ago, that was me." And this other person that kind of, I was at that state, and I'm glad I got the help, and kind of came in. She goes, I realized, again, she had done some behavioral management as long as medication, and my medication, I was having a lot of really inappropriate, she tended to have more heavy on the depressive points. She goes, I knew well enough I needed to get in and get some help and get adjusted. So that was one that just jumped out, because it was the same disorder presenting in which specific medications, and with the benefit of adjustment, there's new ones coming out a lot. So I've left a lot. I know families of medications, but as far as specific ones that are right now, I'm not as familiar with. So I do know, but with right now, I know one that's come out in the last 10 years has been highly, the traditional treatments were pretty heavy medications like lithium, which had
Mostly it's either CBT or DBT, so dialectical behavior therapy oftentimes works because it helps them to try to regulate moods, even though bipolar is often genetically, most likely to get it if you have a direct relative who has it, like a mom or a dad. And depending on the cycling, like there's rapid cycling or there's like where you have like at least like maybe 3 cycles a year. And so that cycling, what that means is they might be manic, and when they're manic, they can literally look like they're all strung out on drugs, they're staying up for days, they're like
tons of energy.
Oh yeah, just trying to get everything done, doesn't require sleep.
Very interactive and social during those periods.
Oh yeah, to the point where
like best friends with everyone.
Yeah. And then what happens is the opposite of that, then they will be depressed, they'll sleep for days, they won't talk to anybody, they'll isolate themselves.
What are some similarities and differences within clients that you have met?
Well, I think it's the cycling, really. If they're rapid cycling, obviously I try to see them more and try to help them regulate or at least acknowledge what's going on right now. And usually it's important to also educate the family, because it can be very frustrating, for the whole entire family. It's very frustrating for the patient because their brain is reacting without their permission.
Yeah, and I mean, I think that just allowing people around them to be aware of what's going on, because, it could be the one day they become best friends with someone, the next day that might change, and they sleep all day, and they hate them, and they talk mean about them, and don't want anything to do with them. So it can be really, really stressful for families,
and the patient.
Friends and the patient, because they are dealing with it as well.
Right. And oftentimes they don't know that they have it. They just think, okay, I'm just recharging right now. Or, and you can take medication for it, but sometimes patients will stop taking the medication because they miss the mania. So they'll deliberately stop taking it because they're leveled out. So when you take the medication, you're kind of level, but they miss the mania. They feel on top of the world. They can do anything. They have all this energy, and they miss it. And
kind of like relatable to an addiction that, like I have to have that because I feel way better when that's happening.
They're trying to actually like self-medicate themselves. So oftentimes they will use drugs and alcohol, which is just they're trying themselves to do it, and to increase that high or stop the low, and that's not unusual. And I mean, I don't blame them. It's very maddening. It's like you have no control.
Yeah, I mean, I would say that the first time that it was very apparent to me, I guess, was working with a teenager with bipolar, and I mean, it was as easy as we would have 2 days in between sessions, and the one day he would do everything I wanted him to do, very interactive, very positive about himself, very good self-esteem. I feel like we were really getting somewhere, and then the next time I would meet him, he hated me and hates life and refuses to interact, and just honestly like 2 completely different people because of that change in levels.
I'll use an assessment. So there's an adolescent assessment that I will use, and then there's an adult one, and that often helps me to determine if that's really what's going on, because oftentimes PTSD will also seem similar. You would see similar symptoms. So I do use assessments a lot.
Well, you said DBT and CBT are effective for clinical treatments.
Right, because it's learning mindfulness, trying to regulate.
I guess helping them be self-aware is really important, because once they're self-aware, then they can assist in that, educating people around them, letting other people know what's going on.
They know when it starts, it's better for them to know, okay, this is
prepare for it.
Right.
Especially for the mania part of it, I feel like they need to prepare and be aware
they want
that what's going on, and what's going to happen.
Yeah, but usually they can feel it starting, and so it's good. Honestly, it's like psychoeducation. They need to learn about what's going on with them, and that it's not their fault.